Great. So I think we shall start off, sir. Is that fine?
Yeah.
Okay. Welcome, everyone. A very good evening, and on this holy day, first of all, I would like to, tell about Holi. A big happy Holi, Rang Birange to everyone. So now, this today evening, we are delighted for the second of the Fetal Vision webinar series, which is held on the last Tuesday of the month. And this series, as we all know, incorporates our dear Bhaskar sir's vision and which aims to bring together the experts and professionals in the field to discuss the challenges and best practices in fetal medicine. So, shall we have the slides, please? Himanshu? So I take the privilege to, of course, welcome Bhaskar sir. He's not unknown to us. He's oblivious. We know that he is the currently he was the vice president Foxy 2017. Currently, he is working as a senior consultant at Apollo Multi Specialty Hospital, Kolkata, and Suffolk Endoscopy Chair Committee Chair and the President IAG 2022-23. He just finished the Foxy representative to Suffolk 2021 to 23, and of course the very well attended, one of the most talked about AICOGs of the recent times, I would say, sir, not bluffing, which was the Kolkata AICOG 2023. He was the organizing chair. So, past president of Bengal ONG Society. And I welcome you, sir, on board to give the welcome address.
Thank you, Shama. Good evening, everyone, and welcome to another evening of learning. As I keep telling everywhere that COVID has left plenty of bitter memories, but the only good thing it's taught us is how to utilize the virtual medium to the full. And now we now understand that the virtual medium is a more convenient, more equitable, and more accessible way of learning. So as much as our face-to-face meetings will continue, I'm a great fan of face-to-face meetings because nothing like sharing a laugh and a cup of tea or any other drink with somebody else. But I think for learning, virtual medium is a great medium. As we know that as you know, we have been doing webinars specifically based to different areas. And this is our maternal fetal medicine series, essentially with a focus on fetal medicine. And I was very surprised that this is the second episode, and the first episode garnered as many viewers as endoscopy and infertility has. So we underestimate the growing demand of fetal medicine. I take this opportunity to all those who are interested in fetal medicine to come and attend the FetoVision conference in Kolkata. It's going to be a focused fetal medicine conference. And the brief is that nobody who's into fetal medicine will speak. So uh, it is going to be an extremely academic conference, single hall conference with four renowned international faculty who are experts in their own field. Dr. Dario Palladini in brain imaging, Dr. Asma Khalil for twins, Dr. Mandeep Singh for fetal interventions, Dr. Leona Poon in preeclampsia and preterm labor screening. So we hope to see all of you there. And we have very exciting fetal interventions workshops on um, simulators for which have not been used many times, and we still have some seats left there. No program, we can only sit and dream of a program, conceive of a program, but it is a collective effort for that to see the light of the day. And I take this opportunity to thank our team, the co-conveners, Dr. Aparna Sharma and Dr. Sita Ramamurthy, and our national coordinators, Dr. Niharika Malhotra, Dr. Prasanna Rai, and Dr. Shama Devdas. I take the opportunity also to thank Conference International, who are our broadcast and publicity partners, and also Lifecell M5, who are our academic partners. I thank all the faculties who take their time out to contribute, to share their expertise with the audience. And I hope that this would be as interesting a series, if not more, compared to the one we had last month. Back to you, Shab.
Thank you so much, sir, for that insight onto the webinar series. And of course, the Future Vision, as we all know, it is going to be another well attended and well organized, sir, I'm sure. So now I think we'll go ahead with the next, the first of the lectures. And for that, I would like to invite the esteemed chairpersons, Dr. Vinita Singh, Madam. I think she'll be joining in some time. Vinita Singh, Madam, she is the additional professor, ONG department at AIMS Raipur. She's the secretary IAG, and her areas of interest are fetal medicine, of course, along with infertility and endoscopy. She's a FMF UK certified sonologist in various categories and also by the FMF Foundation of India and FOXY. She has done her fetal medicine training from Apollo Center and AIMS New Delhi, and of course, published and presented many papers in the field of fetal medicine and gynec endoscopy. So, next slide, please. Vinita ma'am, has she joined in? I believe she'll be joining in some time. And of course, Kanchan sir, he is working as a senior consultant, fetal medicine specialist at the Apollo Hospitals, Kolkata, and the president of SFM of the Bengal chapter. And he is also a faculty in various. We have heard him speak lots and gives all the points and up to the queue. He has published various papers in peer-reviewed journals. So over to you, sir. Since Madam has not joined, I would like you to call upon the first of the speakers and introduce them.
Thank you, Niharika. It's a great pleasure introducing my good friend, Dr. Adinarayan Makam. Well, I know where he works, and you can all read through it through his biodata. He's based in Bangalore, and Adi is a great speaker. What is not written there on his brief CV that he is particularly good at making conundrums into a conclusion and bringing borderline things to a line. Adi, over to you.
Oh, lovely. Thank you very much. Am I audible?
Yes, sir. Yes,
Yeah.
sir.
Okay. Can I share my screen?
Yes, sir. You may go ahead.
Okay. Lovely. Okay. Lovely. First of all, thank you very much for inviting me. When Prasanna called me a few days ago, I started preparing this presentation. It was my one of my favorite areas where we find little bit difficulties. How do we make it easier for our life, and how do we go from darkness to the brightness, from confusion to clarity? So in life, not always it is straightforward. A lot of difficulties. So many times we come in the border, we don't know which way we need to sway. So if it is black and white, life is easy. But unfortunately, it is full of gray. The idea is we need to move from darkness to brightness, clear our confusions to get some clarity. But unfortunately, again in fetal medicine, the gray, it is too much. So we live in gray world. So we cannot stay in gray world. We need to get some clarity, either black or white. So how do we reduce this gray into small area? Sometimes we take away the gray area and push into black, or can push into white. So can we do this one? Not easy. So sometimes we have difficulties. So what I've done, we have taken last few days of cases and see how we can clear our borderline features. We can get borderline, we can stay in borderline in ultrasound findings, making a diagnosis, and management. So we will find a lot of difficulties and we will come in between. How do we solve this borderline where is my next 20 minutes. I don't know whether 20 minutes enough, but I'll try to finish as quickly as possible. I've taken few cases from the last 3 days, and I sat down from 4 o'clock till now and amalgamated all the cases. I've not had time to go through the slides, so if there is any glitches, please pardon me. So, okay, first case. So this was referred for a routine NT scan, and on the transabdominal scan, it was a twin. One of the twin died. The other NT looks okay, but the nasal bone looks less hypoechoic. So what do? We use some tricks. What tricks? We change the dynamic contrast and see. When I increase my dynamic contrast and went into gray map rather than sepia, so the nasal bone looks almost similar, echogenic. Is my pointer is shown? Okay. So the nasal bone looks as brighter as the skin or the bone. So was I happy? She was a 40-year-old lady. Second marriage, first marriage, she lost one baby with ectopic pregnancy. So she's very desperate. Okay. So now I need to make sure that whether the nasal bone is there or not. So what do I need to do? I will struggle a little bit more. So I come back again after some time. Still, the nasal bones are not very clearly hyperechoic compared to nasal bone, the skin over the nasal bone. So after some time again, I saw the nasal bone appeared hypoplastic, but the CRL was only 57. So if you try and look at the nasal bone before 65 millimeters, many times you may not see the bone, you may have to wait. But what do you do when the patient comes to you? And would you use the nasal bone in your day-to-day routine practice? According to your institutional policy, you need to see. So ideally, we need to wait until 65 millimeters before we call it as hypoplastic nasal bone. But this is a 40-year-old lady. What should I do? So how do I go about my findings? Will I tell her that it is a hypoplastic nasal bone, or do not use nasal bone in my clinical risk calculation, or will I ask her come after a week so that the CR will be more than 65? So now she is very anxious. When I was speaking, she hears what I'm speaking to my fellows, and she was worried. So what did I do? So I did not want to hide anything. I took her into my counseling room, and then I explained what I found and what it means, and I gave her all the option and asked her to wait for another week or so. Obviously, she was very anxious, and finally, she decided to go ahead with the investigation, which is probably fair enough in our ecosystem, especially when she is 40-year-old lady. If it looks like a duck, and if it is walking like a duck, and if it is quacking like a duck, it's probably a duck. So we need to take all features into account and make a decision. So this is another case, 30-weeker. We were following this lady very closely because previously she had lost a baby at 26 weeks because of PPROM, and also she had a severe preeclampsia. She's again 39-year-old lady. She's a doctor herself, and since NT scan we were following, she developed into early onset FGR, and we were following. Day before yesterday, she come 30 weeks one day, absent diastolic. It was absent diastolic from the last 2.5 weeks. Now they were all ready to deliver this fetus. Pediatricians were very worried about necrotizing enterocolitis, and patient had a steroid and a Maxilf as well. But obstetrician and patient did not want to deliver. So I said, ductal stenosis looks fine. What else I need to see to help her is I was looking for breathing movements. Baby was moving, but I could not get breathing movements. So every time she comes, she knows that we look for a breathing movements. And she was anxiously asking, is there a breathing movement? Is there a breathing movement? I could not get the chest movements to see. So what you could do, you can go into the nostrils and see whether the fluid is coming in and out. If the fluid is coming in and out, it is doing a breathing movement, may not be vigorous breathing movement. So this gives a lot of confidence that BPP is normal. I did not want to deliver, or I did suggest that we will wait for a few more days, maybe 2 days, and see her again. So sometimes when you are in the borderline, when you have to make some decisions, some tricks like this may help. So another usual borderline cases is when the head circumference is smaller. So when the head circumference is smaller, it may be constitutional or it may be due to underlying so many reasons. So how do we deal with that? So this one, the minimum you can do is to do an advanced neurosonogram to make sure the brain looks normal sonologically. So we did the biometry, whatever we can measure, the CSP, fourth ventricle, and I could not get the corpus callosum in 2D. Of course, I could do it in 3D, but I wanted to do it in 2D first before I go into the 3D. So the baby was in bridge position. I could not get the corpus callosum. What should I do? I cannot do an ECV to make the baby head down and do a transvaginal scan, although I'm trying to do it. But doing here in India, if by chance the patient miscarries, the whole blame comes on you. So I would rather manipulate, if at all, very minimally, not vigorously. So one trick which we can use is a lotus position. So the lotus position is you make the patient sit up. And once you sit up, you can put your probe vertically on the baby's head. So your life becomes a little bit easier. So I could get the corpus callosum nicely. I could see the vermis nicely. So this is another trick we can use when you're in trouble. And another thing what you have to know, when there is a head circumference is smaller, you need to know whether this is proportionately small or disproportionately small, because vast majority of the small heads are normal heads. So when you look at the ratios, you probably will get an idea that this is a proportionately small head, not a microcephalic head, and it is not too small an head. So our counseling is geared towards reassurance rather than worrying and investigation. So in this case, there was a question about overriding. So when this overriding is a bigger trouble, many times it looks normal, many times it looks overriding. Of course, you can look at the pulmonary artery size, but many times pulmonary artery also may be normal. So it will be very difficult. Of late, I've learned from oronozole, pediatric insonation, that is, you get a biventricular short axis where you look at the tricuspid valve en face, you lose the atria, you lose the ventricle, and then move downwards to see the interventricular septum and the commitment. So this is, many times it has helped me over the last 2 years. Before that, I used to struggle a lot whether to say whether it is overriding or not. It was used to be difficult. Now it's a little bit easier, but nevertheless, sometimes it's very difficult to make a diagnosis of overriding at 20 weeks. You may have to wait for a little longer time. So now how do you get there? So easiest is when you're doing an axial sweep, you rotate the probe 90 degrees. Then you sweep from one side to the other side, sagittal sweep. So that's how you get into the en face views. I'll show you. Then once you get an en face view, it is much easier to see the septum and the commitment of the great vessels to their respective ventricles. Is my video playing normally? Okay, fine. So then in that position, you acquire a quick 3D or a stick volume, 7.5 seconds, and then you can play with this volume. So Prasanna obviously will take us through the special 3D, 4D usage. Here, this case, once we get this one, you can render, you can actually see the 3 tricuspid valve and 2 mitral valve leaflets, and you can see the interventricular septum nicely, especially towards the outflows. If it is outflows is more important, you can make a diagnosis of overriding or inlet VSD in this section. This is for my E8 machine, not E10 machine. So you could do in all mid-end and high range machines. So 3 cusps you can see, 2 cusps here. And then in a multiplanar, you can go and keep your reference dot at the aortic valve and do a Y rotation. You get the complete interventricular septum and the commitment. And you move to the pulmonary and again make sure that the pulmonary artery is committed to right ventricle. So this is much easier. So how do we get there? From an axial sweep, rotate the probe 90 degrees and then acquire a sweep and then use the reference dot to look at the commitments. So this is very useful. As I said, off late I'm using it for my convenience and it is making my life a little bit easier. So this is one case where you can see in the on-force view, the tricuspid valve, mitral valve, and both atria and interventricular septum, and you can see the aortic valve saddling over both ventricles. You can see the aortic valve open and close, and there is a VSD, malalignment VSD. So this view is, if you are not using it, I request all of you to try this one, and it is actually very good, and certainly it helps me. So you can beautifully you can see the aorta saddling over the both ventricles. Another trick you can use is you bring the baseline down, use only one color. So if you use one color, the blood moving towards you will be red and away from you is orangey, greenish orangey. In this way, you will see the blood coming from the right ventricle is not going to aorta whatsoever. Aorta is clean. So this is something nicer. And if you want to use this, I request you to get a little bit of blue, not complete red. In this way, you can actually see the endothelial flow. Flow towards the endothelium is less faster or slower. So that gives blue tinge at the borders of the columns of the blood moving. So in this way, you will know that there is no pulmonary blood coming into the aorta. So this again, another feature you can use when you're in trouble. Okay, another case, they are referred as a monochorionic monoamniotic at 9 weeks. So at 9 weeks, you should be able to see the membranes. So this lady came for asking for a reduction because it was a monochorionic monoamniotic. It did not make much difference. It is monochorionic diamniotic, but of course, it was a better diagnosis. When I was scanning, I saw 2 embryos of a different size. Then it's a little bit of trouble. Is this embryo is already shows some signs of a UGR or early signs of TTDS, but when I actually measured, both fetuses are, both embryos are of a same size. When you want to do a CRL measurement, doing it in 2D can be a little bit difficult. But in 3D, you can get whichever plane you want, and then you can get a nice section and then measure. The measurement will be a little bit more accurate than your grayscale measurement. So, but actually both fetuses were normal and nice picture for the mother to take home. We're not supposed to give 3D, 4D in Karnataka anymore. So this is for our sake we have done. So this is another case referred for corneal pregnancy or interstitial pregnancy. This can be a little bit difficult sometimes to be sure. But what helps is when you look at the endometrial then it is intrauterine. because it is stayed in the interstitium of the fallopian tube. So this was easier for me to make a diagnosis in 2D, but this lady is again very anxious. So then, and also I had to teach my fellows. So I did a 3D, and in the 3D, in a multiplanar VCI, it was almost clear to say that it is intrauterine, it is not extrauterine. But I wanted to make it a little bit more beautiful and then use the buttons. And this is a defined magic cut where you can define the area and do a defined cut. The depth you can define. And this looks beautiful for your referral doctor. They are much more confident than before when you produce images like that. Is another case, 13-weeker referred for increased NT. Yeah. I mean, if it is a real life, I could have asked you a question, but I will only answer my question. The little finger was a little bit deviating towards the center. That is a clinodactyly. So clinodactyly is of course, is a very soft marker. It is not necessarily abnormal, but that alerts you to see more. So when you, again, we can see it is deviated and it's persistently deviated. It is not positional. So next thing I will see is the other limb, that's the lower limb. Even the lower limb, one of the toe, the little toe, was deviating towards the center. Oh, I've never seen that before. So I was thinking whether I'm making up or is it really there? And this again 340 really helps. And you could see one of the little toe was deviated. On the right foot it was fine, and the left foot it was deviated. Whether it's useful or not, we'll see. Because I found two markers, then I extended my examination into a TB scan, and then in the TB scan, when you do the survey, you saw several findings here. So what all findings we saw? We'll go back. You can see the small bowel is coming out. It's a small omphalocele. There are multiple heart cysts. And in the thorax, the heart is deviated or the mediastinum is shifted to right side. So, and this appears to be liver. So is this a CDH or an eventration? That was my next question. CDH and eventration not necessarily always easy to differentiate before birth. Even surgeons find it difficult, but as much as possible, we should be able to differentiate. What all features you see? There are, of course, it's not an eventration class. The best way is to get the VCI. I'll show you that in clip. So in this one, again, when you're doing the 3-vessel bladder, you need to demonstrate 2 umbilical arteries next to the bladder, and also you should demonstrate extra abdominal umbilical arteries. Then only your anti-abdominal wall is evaluated. In this one, a small omphalocele. This we would have missed if we were careless or if you're not very careful. And so I showed you this mediastinum is shifted, and this appears to be liver. This is a lung. So is this really eventration or a CDH? CDH at this stage is very serious. Even eventration is also, but you could see the diaphragm clearly, and the lung is sitting on a cap. So this one is better when you use VCI. Here you can see this is the lung shadow here. This is the diaphragm, and this diaphragm is shifted up. Only small amount of lung is there, a good amount of lung here. So this is a eventration most likely. Then I was evaluating the heart. You can see the tricuspid regurgitation. So tricuspid regurgitation was very evident. I put a spectral Doppler. You could see the tricuspid regurgitation. Mind you, if you reduce the PW power, it disappears. And an early systolic can become pansystolic. So this depends upon your PRF, period wave power, pulse wave power. So that you are to be mindful. Okay. Right. This is another case. One of my fellows asked me to see this one because he heard the lecture the last Friday about deviagenesis in our theory class. Otherwise, he was never used to see. And also, I was not seeing a few years ago. Now I'm started seeing, and now you find all unusual findings. In this case, there is umbilical vein varix. Umbilical vein varix was there, and the left superior portal vein appears to shunt the blood into the left hepatic vein. It was not an easy case to figure out, and this actually figured out by my one of a nice fellow, bloody fellow. Otherwise, I would not have picked up. And then you put the color, and you can see this is a left superior portal vein draining the blood into the left hepatic vein. The left hepatic vein is bigger than the middle and the right one. So it supports the shunting. So this was a complicated case. I will share the details later, running out of time. This is another interesting case. Day before yesterday, we saw referred because of the amniotic band. So it was not of course, the BMI is bigger than mine, not an easy case. So there was subtle amniotic membrane-like thing. And then I saw after some time, still that amniotic membrane was there. So I was wondering what should I do? And obviously, when things are not clear in TA scan, we go to TV scan. Of course, you can do TV scan routinely, but if you're not doing routinely, certainly in indicated cases, you got to do that. Many IVF patients are reluctant, and some of the very anxious patients are reluctant, but depends upon your counseling. Once you counsel, they understand the need for it. And then when you see this one, you can see the part of the baby inside the amniotic cavity, and part is extruded into the extraembryonic coelom. So this was not forthcoming in the abdominal scan. So whenever you are finding a borderline findings, you need to extend. You need to go into the transvaginal scan. Sometimes you need to see after some time. Sometimes you need to turn the patient and ask the patient to cough. And so many tricks we can do. So you can see beautifully the sac of the baby inside and of the baby outside. Obviously, this is not a good news for the mother. Unlikely this baby will make into any reasonable gestation. So possibly termination would be the best idea for this one. Otherwise, they will have a lot of trouble. Okay, this is another case. I think, how much time do I have? Okay. So this referred as one limb is shorter. So when I looked at this is the same baby, right and left I color coded. The right left foot tibia was normal or 30 millimeters, and the right side one was 6 millimeter, 20% shorter than the other one. So would you normally see both feet? Well, not in real practice, but if both feet are not at the same level, then you start thinking whether there is a limb discrepancy. The fibula was also shorter, 30 and 21. You can see the difference, about 20% difference. So you do. It's not that I was hopeful, but you could see nicely anterior artery and the blood circulation. It's not at the moment vascular, but earlier little bit of vascular ischemia may be the reason why it has happened. And again, when you have some abnormality, you have to extend. So here, when I did a TV scan, you could see the foot is consistently dorsiflexed and did not move. So there is some abnormality here. So you can do the 3D, 4D if you want, and not absolutely necessary, but it was nice to do 3D, 4D to look at the length discrepancy and the attitude. And then we don't stop there. We look at other bones. When you're looking at other bones, in the proximal end, I could see the stippling. And in the tibial end also, there was a little bit of stippling. But one of my current fellow said, sir, that's a patella. I did not believe it is a patella. So, but when I looked closely, this is the tibial condyle. And then in front of the tibia, there is a patella. So patella should not be ossified before birth. So then it is must be a premature ossification syndromes. The workup is extensive. Then we will look at the spine. We don't. We wanted to see whether there are any abnormalities. We could see the coronal clefts. Again, coronal clefts can be normal variant. In the past, we used to worry, saying that it is maybe associated with chromosome abnormality. Obviously, but actually, all spine develop like that. So many patients, if you closely observe, you can see the coronal clefting. Again, you can do a 3D to get a little bit more idea. This light we can shine from different angles. This was not absolutely necessary. We already made a diagnosis in 2D. Using a silhouette, you can see the coronal cleft nicely. Only the lumbar region was affected. Okay. So this is maybe last case. So this one referred as clubfoot. So unilateral clubfoot, it was not a difficult diagnosis to make. But when there is a clubfoot, as good fetal medicine principles, what do? You look at other same system abnormalities or other system abnormalities. So let's see that. When I was evaluating the heart, what is the finding? So what is striking here is a area behind the heart. It's a double barrel. This is aorta, this is a zygous.
Adi,
Yes.
sorry to interrupt. It's very interesting presentation, but we are overshooting a bit.
Okay, I'll stop this one.
Thank you.
Okay.
Wrap it up. Take a minute or two.
Last slide, last one or
Yeah.
two something. The case is finished. So here in this case, there was a polydactyly which was not seen before, and the pre-auricular tag. I don't know whether I was imagining or it is a vernix or it is actually an abnormality. So I've actually included several cases. I'm glad I took out so many of them. So finally, so how do you get some clarity in ultrasound findings, diagnosis, and management? Findings, when you are not sure, you use a lot of tricks, including sending the patient away, seeing them again, making them sit up, phoning a friend, looking at the literature, looking at the images in the ultrasound in the net, and so many things you can do to get some clarity. Diagnosis, it is amalgamation of all the findings. You're not going to make a decision or make a diagnosis by one finding. You need to look at other findings as well. The famous saying, you cannot cook a dish with one ingredient. If you cook a dish with one ingredient, it is like Western mashed potatoes, nothing else. So it's not tasty. You need to add tadka. You need to add several ingredients. From management perspective, if you're in a difficulty, involve multidisciplinary. You do a MRI. You involve the pediatric surgeons, pediatric consultants, and all sit together and when you play everything in front of the patient, and patient makes a decision. And when we are in difficult situation, we need to split up blame. So in UK again they say when shit hits the fan, you split the blame. Okay. So preparing for this talk, just now I spoke to Prasanna. My borderline findings is converted into clarity and a lighter note. And a serious note, we need to spread the knowledge. We need to go from darkness to brightness, and involving the multidisciplinary team will make our life, patient's life, better. I stop here. Thank you very much.
Thank you, Adi. Very enlightening presentation. Over to Niharika now.
Thank you.
Sir, if you would want to pass on some comments or some remarks on the presentation now, or we shall go ahead with the next.
Probably at the end.
Yes,
Let's
yes,
call the
that's-
next speaker up.
All right, all right. So, Dr. Vinita, she's joined in. Vinita, ma'am.
Yes, ma'am. Yes,
May
ma'am,
I?
I've joined.
Yeah,
Can you?
yeah. Can I call upon you to introduce the next speaker, Prashant Acharya sir?
Dr. Prashant Acharya is a very well-known fetal medicine specialist. We all know him. He needs no introduction. He's a medical director and chief consultant, Paras Advanced Center for Fetal Medicine, Ahmedabad. He's an honorary fetal medicine consultant at SVP Hospital, Gujarat. He has so many fellowship to his credit, ICOG fellowship, and he's also a board member of ICOG. He's ambassador of Asia and Pacific region. He's international faculty of speakers, first Indian to be honored. He belongs to BITS committee. He's a member of advisory board member since 2012. He's a founder trustee Indian Society of Ultrasound and Obstetrics and Gynecology, and he's a vice president. He was a vice president in the year 2012 of Foxy. So it's a pleasure to introduce him. And so we are eagerly waiting for your presentation. Welcome you, sir.
Thank you very much. Can I share my screen? Somebody
Yes,
has to
sir.
make me.
Yes, sir. You may start the share.
Can you see my screen?
Yes, sir.
Yes, we can.
It's on the run. Yes, sir.
Yes, sir. Yes, sir.
Okay. So what I'm going to today discuss fetal echo, what you should know at least. So this is what is a basic kind of presentation which I think everyone should understand and everyone should be able to do it. And when you go or when you join your clinic tomorrow morning. So that's what I'm going to take you through, and that's what my point today. What I'm going to discuss. Thank you very much for your kind words, madam. And it's all about how you look at the fetus and how you look at the fetal heart. I always say that if you do whatever you always did, you will get what you always got. To get what you never had, you must do something which you never did. So whatever you have done till yesterday, if you do it tomorrow, you are going to get the same. But the moment you understand the fetus much in detail, then you will be able to get something which is better, which you haven't got it today. And that's what my aim is, to make you more well versed with the field cardiac anatomy. And if even if you will be able to diagnose 6 out of 10, it is 60%, and you are much better than anybody in United States, or practically more better than anybody in European countries. So that's what my aim is, because there they can, the diagnosis is 40%. You can go to 60% straight away. Follow basic rules. That's what I always say. This is still 6 decades old antenatal care, which still we are following once every 3 months, then every month, then every 15 days, and then last month every week. Then Kipros tried to invert the pyramid, which didn't work for India. So we thought that because in India you can't have one examination at 12 week, then one at 20 week, and then you follow it at a 9 month, which doesn't work in India, because there are many complications, many things which you are going to miss if you follow this inverted pyramid. So what we found out is we call it as a tube of pregnancy care. It was published in White Journal and it was presented in the World Congress. We said that one, it is 3 months, where you do a classical first trimester evaluation, includes your NT or aneuploidy, early malformation. Now NT and nasal bone, they are going to die very soon. It will be taken up by an early anomaly scan, early fetal echocardiography, and more about it's an early twin evaluation with diagnosis of monochorionic and dichorionic. And then goes to the 5th month. That's what we all are doing routinely. Then the next is going to be at 7th month, 29 to 30 weeks, where we diagnose late developing malformation. Then you diagnose early growth restricted fetuses, because it only follows the classical cascade. And the entire growth restricted fetuses, these group constitutes 30%. So there are 70% which are late developing malformations, and that you will be able to diagnose only after 34 or after 32 weeks of gestation. Most important, at 7 months, you will be able to identify the placental accreta spectrum. So it's PAS, that's the accreta spectrum, you will be able to diagnose, and you will be able to shift in utero at appropriate place if at all you are not doing the thing. But what you can do it for the fetal heart, at 3 months, you will be able to diagnose major cardiac malformation where more ventricles, more atria, major malformations you'll be able to diagnose at 3 months of the gestation. At 5 months, you'll be able to do a comprehensive diagnosis, probably with a better accuracy than 3 months. But here, the counseling and investigation for 22q11 deletion. Now it's not only 22q11 deletion, but it's about whole exome sequencing and microarray. Both should be done when you find a cardiac malformation. At 7th month, you will be able to diagnose a cardiac block, coarctation, critical aortic stenosis, and they will appear only at that time. But more important is you will be able to diagnose and prognosticate certain malformations like tetralogy of Fallot or double aortic right ventricle better at 7th month of pregnancy. And same thing, you can plan the timing of delivery and the place of delivery when you are having fetal echo, some abnormality at 9 months. I always put it as a similarity between the driving a car and doing a fetal echo. If you follow the rules, if you take some precautions, use the Gazette Optimum Best, you are going to get it the best result. If you do not know, don't try. You will end up in a disaster. So that's what I always say about a fetal echo and driving a car. Once you know how to drive a car, you will do it at spinal level. You don't use your brain while driving the car. This is exactly what happens if you follow certain rules. And these rules are two good guidelines. We call it the guidelines. AIUM guideline, that is good. Another guideline is ESWAG guidelines. And in ESWAG, they have said that the first fetal echocardiography starts not at thorax, it starts at abdominal circumference. Identify the stomach and aorta. They are situated on the left hand side, and inferior vena cava, that is on the right hand side of the fetus. So that you have to identify first, and to identify left and right, you don't use the stomach or apex of the heart. Why? Okay, that's left hand side. It's actually we use the identifying fetal left and fetal right side. We are going to discuss that part. From AC, you go to the fourth chamber, and for I tell you one thing, that it is not only grayscale, it's an outdated concept. It has to be color or HD flow with a grayscale imaging side by side. That's how you perform from four chamber view. You go just a little up where you will identify the left outflow tract and then origin of the left outflow tract. You will go little up, you are going to have a pulmonary bifurcation. When you go little up from pulmonary artery bifurcation, eventually you will have a formation of tracheal V, and that's what we call the 3-vessel trachea view. So, all in all, if you identify situs, if you identify the abdominal circumference, if you have identified good normal four chamber, and if you identify 3-vessel trachea view, if these are normal findings, then your cardiac structure is 90% normal. That much diagnostic accuracy you can come across if at all you are identifying these little structures at appropriate place. See, it's all about the advantage of fetal heart is it only changes the size during the advancement of the gestation. At 12 week, it could be of chickpea size. At 22 week, it is of olive size, and at 32 week, it is going to be the size of an almond. But the internal structure doesn't change. It will have two ventricles, it will have two atria, it will have one aorta, it will have one pulmonary artery which bifurcates. Practically, the structures are same. Because they are only smaller structures, what you need to evaluate the smaller structure is a high resolution probe, better machine, a transvaginal approach. That means if the smaller is the structure, if you take a high resolution probe, and if you can have these flow and a better technology, then you can identify all sorts of cardiac malformation right at 12 weeks, and it is going to be easy. Now, before going anywhere, before going to learn the fetal echo in basics, we need to understand the anatomy. Here I have opened the fetal thorax, and when I open the sternum, the first chamber which comes is the right ventricle. From right ventricle, there's which goes straight toward the spine. On the side, you will have a left ventricle where aorta arises, and it gives rise to 1, 2, and 3 branches. So it is a right ventricle which is just behind the sternum. Once you have got this idea, then let us try and see what the structure is. The big structure, which is this, is a thymus. So thymus is that big in the fetal life. You have got a biggest chunk of structure which is lying there. It is thymus. And if it is smaller, you have a thymic hypoplasia, which can be in the moment. Let me lift the thymus for you, and then let me tell you that this is a right ventricle. right ventricle. This is the left ventricle. And from right ventricle, you have got a main pulmonary artery which arises. Then it continues. Then it gives rise to branch to the left lung. It gives rise to branch to the right lung. And then it continues. And this continuation of this, so it pulmonary artery, main pulmonary artery actually trifurcates, not bifurcates. It is going to give rise to right lung, left lung, and then it continues the ductus, what we call it as the ductus arteriosus. So you will have a ductus arteriosus which will be continued and which is going to join. So from left ventricle, you have got the ascending aorta, which first go towards the right shoulder, then it takes turn, it gives rise to first branch, second branch, and then it gives rise to third branch, and then it goes below. So these, after the third branch, this area, what is known as aortic isthmus, now it has got a huge value in identifying the growth restricted fetuses and evaluation of the growth restricted fetuses. So once let me go a little faster and make that portion a little bit more clear. So because okay, let me put it this way. So here this is the main pulmonary artery, ductus arteriosus, third branch, second branch, first branch of aortic arch. So this area this is where you find a V formation. One is here, and that's what we try to evaluate the tracheal V. And the moment you can identify this tracheal V, which is going to be formed like this, let me still stretch it to you. This is what you are going to. Now here you can see that this is joining here and this is joining here. So these formation of V at the level, why we call it the tracheal V, because at this level, at the arch of the aorta, the trachea bifurcates into the left and the right branch. So that's the reason, because they all are having similar level. So we call formation of V at the level of trachea. So we call it the three vessel trachea view. So these three vessel trachea view, that is one of the higher level of evaluation, and that's what we will be looking for. So fetus, identifying fetal left hand side, we usually utilize, because my left hand is free, we scan with the right hand. Because my left hand is free, we draw a doll like on our hand, and this head becomes the fetal head, and the knuckle becomes the spine. So if the baby is vertex left occipital anterior, so the probe is going to be here. So the probe which is going to be and near the probe area is going to be my right hand, and the thumb become my denominator for the right side. So I put it this way, that this is the head, this is the spine, posterior spine. So the thumb, it is like me where I'm standing or sitting. So my right side is towards my thumb, and that is exactly where thumb becomes the denominator. That's one place, and another way is clockwise and anti-clockwise that we usually don't follow. We follow the draw on a doll on your hand. That makes my life easy. Once I have identified fetal left hand side and fetal right side, then I start examination at abdominal circumference, and I see that okay, aorta is on the left hand side of the midline, stomach is on the left hand side, and the inferior vena cava is on the right hand side of the midline. That's how first three structures, if they are not following the rule, that means you are coming across to some of the malformation as far as situs related issues like heterotaxy or the situs inversus and whatnot. That can be a part of your evaluation. One of the most important easiest point is to identify the cardiac axis. In the cardiac axis, one line is drawn from the spine to the sternum, and another line which is drawn through the interventricular septum, and the angle which is formed, and this angle what is known as cardiac axis, and it has to be 45 plus or minus 10, because this cardiac axis, where it is going to be abnormal, it is going to be left axis deviation. If it is deviated toward the left, if the angle is more, you may have conatrial trunk tetralogy of many outflow tract malformation you may have, like TGA, double outlet right ventricle. Maybe you may have the which is going to be, this is one normal I have put it across, or tetralogy of Fallot, which you may have quite an abnormal thing, and a common arterial trunk. Everywhere you will have a left axis deviation. When you have got a left axis deviation, you please look at outflow tract, which is going to be quite abnormal. So again, rule of one third. A cardiac position. When you draw a line from midline 2/3 of the heart is going to be on the left-hand side, and 1/3 is going to be on the right-hand side. That is where that's how cardiac position is going. Fetal heart is going to be positioning itself into the fetal thorax. It will also have an area like 1/3 is going to be heart, 1/3 is going to be right, and 1/3 is going to be the left lung. That is also is going to be the rule. So that is this that's how it follows. 1/3 is going to be right side, 2/3 left hand side, 1/3, 1/3, 1/3 as far as cardiac size and the area is going to be. So that's how it follows. When you have got a cardiomegaly, that's how you diagnose cardiomegaly, or a narrow thorax or a narrow heart. That's how you diagnose, because it is going to follow. If you have got out to out measurement here, just add 10% to the gestational age, and if it is following that, that is the normal heart. The moment it exceeds, it is cardiomegaly. When it remains normal, but still when your CT ratio is altered, that means you are dealing with a small thorax. It's not the cardiac problem. So you need to understand that, okay, that's how you identify that. Now, going after abdominal circumference, axis, position, and the size, you go to the four-chamber view plane. And simplest one, four-chamber view plane that you identify, you should be looking at 12 points. Look at a situs, look at the axis, look at the size. We have already seen. Look at the two ventricles. It has to be contractile at a similar strength. Size is going to be quite equal. Apex is always going to be formed by the left ventricle here. But one important point is in the cardiac, in the heart, whenever you look for the intracardiac anatomy, that means you are looking at intrachamber anatomy, you will have a moderator band. You will have a moderator band which is going to be situated in right ventricle, because this is the sternum. Just behind this is always going to be the right ventricle. It should be there. So you'll have a moderator band. The surface of this is interventricular septum is going to be irregular. On the left-hand side, the surface is going to be quite smooth. It's going to be apex is formed by the left ventricle. Then one of the important clue is this is a tricuspid valve, and this tricuspid valve is always should be towards the apex. Mitral valve is always going to be away. So that is what it tells you that, okay, this is normal finding. This tricuspid valve here, mitral valve here, interventricular septum, and this is intraatrial. So this is a formation. This is what is known as crux, and it should not be at same level. The moment they are same level, you call it as linear insertion of AV valve, and you may have many cardiac defects associated with linear insertion of AV valve, and that's what we always try to tell you. The atria, most neglected structure. Right atria, which is going to be connected to the right ventricle, and left atria is going to be connected to the left ventricle. That's all we know. But the thing is, when you have got a spine should be kissing the aorta, and the aorta should be kissing the left atria. When you find there is a gap here, that means you are talking about many malformation. It has to be thin line, white tissue structure only has to be seen. And when you don't find that, there is something here, extra vessel, you are talking about total anomalous pulmonary venous return, and that's what you should be looking at. One more point. Left atria should drain these two pulmonary veins into it, whereas the right atria is going to be bald. This is what we call the bald atria. There is nothing is going to be piercing inside the right atria. Here it will have on the left atria. The one typical thing is it is going to be pierced by all four walls. On the right hand side, you have got a foramen of oval. On the top, or what we call it also the inferior wall, you will have the four pulmonary veins which is going to be there. Here it is going to be the mitral valve, and here is going to be the ridge, what is known as Commodant ridge. So, or all four walls, you find one or another structure, and that's what you need to understand. That's about ventricle. That's all about atria. Look at interventricular septum. Always better seen when the heart is lying horizontally, or what we call as the basal view, because it's a principle in ultrasound. The ultrasound beams are following at 90 degree. These are the structures which are hitting at 90 degree will be seen better, not the structure which hits perpendicular. So that is how The moment I am interested in looking at the subtle defects in the interventricular septum, I will be turning basal four chamber view, where the valves will not be seen that good. Veins will be seen better because you will have isolation right like this, and that's how you will have a good pulmonary veins, which is better seen. So if I want to isolate, have a good one basic structure, I will not prefer apical four chamber view. I'll always prefer basal or little 45-degree angle. That's what I will always prefer to look for the structure if I have to see one image. Two AV valves, which I have told you, tricuspid and mitral valve, two pulmonary, this is what we have already seen. Rhythm, it has to contract very regularly with a regular rhythm. There should not be more than 4 mm fluid in the pericardial cavity, because that's what, up to that fluid has to be there. Otherwise, it is going to have friction with the pericardium, it will have more problem. So the till 4 mm fluid, which is a normal finding, and then area behind the heart, as I told you, there should not be any vessel. So if the moment you see this 12 points here at the interventricular septum or a four-chamber view, then your evaluation is going to be quite all right for that particular point. Interventricular septum, that's what, as I told you, that look at what I was trying to tell you here. Here is going to be a basal four-chamber view where you find the good, brilliant interventricular septum that nicely. Foramen of oval, pulmonary veins, interventricular septum seen nicely. That's what I will always prefer, because the interventricular septum may have it's located at a differently. That's what we can always see and identify. Okay, that's what interventricular septum confirm with a Doppler color, and that's how you can see. A crux, as I told you, you have to because atrioventricular septal defect, many kinds of with the bradycardia, without bradycardia, but look at, you will be able to identify this is the normal crux. You have got one valve and the valve interventricular septum intact. Look at these. There is no crux, and that's what atrioventricular septal defect is, and you should be able to identify. Commonest finding where we are trying to look at septo-aortal continuity, where septum, interventricular septum will be continued till the wall of one of the wall of the ascending aorta. So if this is not continued, and another wall which will have a continuation with the mitral wall, that's mitral valve. That's what we are always going to be looking for. Let us try and understand these. So you have got, if I remove the myocardium of the vessel, then that's how the angle is going to be. So draw a line in interventricular septum, and that's in septo-aortal continuity. There is going to be an angle, just like putting it across the line here and line here. So these angle, the outflow has to be with that angle. If the outflow is not with that with an angle, that means you are dealing with many outflow tract malformation, and that's what most of them are going to be: the tetralogy of Fallot and overriding of aorta. There may be 6 different causes of overriding of aorta, and because the time doesn't permit, we are not going to discuss that part. Coming to pulmonary artery, simplest one. It is if you look at it has got 2 different kind of course, which we always say that you may have a short axis and a long axis view. It will tell you that, okay, you may have a typical origin pulmonary valve, and you have got origin pulmonary artery, and it divides. Or you may have a straight pulmonary artery which you can identify. And the whole thing is what I say you trifurcate is, look at this specimen, right? Outflow tract. This is where one main pulmonary artery. This is a ductus arteriosus. One pulmonary artery. So that's what I want to say, that it gives you 2 branches, and that's what it is going to have, the 1, 2, and 3 branches, and that's what I always say. Then coming to the arrangement. The arrangement is that you will have, I have put the needle here just to say that, okay, this is one needle in the right outflow, this pink is in left, 18 gauge needle is in right outflow, and 24 gauge needle is in the left outflow. The relationship is they are crossed at 90 degree, and because they are organized like this, crossing across, because this is happening because of the embryology and the development of the septum, spiral septum. it makes this curvature. The moment you have understood this curvature, then and then you will be able to identify. So how this is located? If you catch hold of the pair in front of the thorax, in front of your just behind the sternum, the base becomes the left ventricle. It should go towards the apex is going to be towards the right shoulder. That's what an ascending aorta or origin of the aorta. When you cover your hand and put your thumb towards the sternum, that becomes pulmonary artery. That's how exact your 90-degree arrangement is going to be. And once you understand once you understand these relationship, you will have everything which is going to be much more clearer to identify. So three vessel trachea view. This is here the origin where you are having just above the fourth chamber three different vessels: pulmonary artery, aorta, superior vena cava, left to right, size wise, anterior to posterior. So all three ways it follows size wise left to right, then the anterior to posterior, and it is the pulmonary artery, aorta, and superior vena cava. If any of the vessels are of same size, think about some malformation. So it has to be, and the tracheal beak points towards the left hand side. So we will try and see how these things are. So in three vessel view, this is what I will put it across. So a three vessel view, you will have three things to be identified. Most important is going to be the thymus, which is you will be able to identify a three vessel trachea view, and this is what you one has to understand. In three vessel view, you look for the size, alignment, arrangement, and number. So you have got PAS, anterior to posterior, left to right, and also the size wise. There should be three vessels, not two, not four. Any extra or any deletion is always will have problem. So let us have a look at a clip. So from a four chamber view, the moment you will go little up, I know that okay, four chambers looks fine. I can see that both atria, ventricle, everything is fine. Once I go just little above, this is going towards the right shoulder. This is left octotract, and this is crossing because it is the blood is flowing in a different direction. You'll have different color. So these difference in the color tells me that okay, they are crossing good. When I go little up, now here I can see the pulmonary artery bifurcates into one and two. So here this is the pulmonary artery which bifurcates here and it bifurcates here. This is what it is going here and it is here. Once here I have seen this, then I'll go little still up. I will go little up. Then I know that okay, right now I'm trying to evaluate three vessel view: straight pulmonary artery, aorta, and superior vena cava. When I little go up, I do expect okay. Just have a look at this. At this point, this little area, this is one vein which goes into the superior vena cava. That is the azygous vein. So azygous will go here into the superior vena cava. Then at this point, if you can see, this is a bifurcation of the trachea, where you see the bifurcated trachea, which you can see. And from here, when I go little up, I know that I'll be dealing with a V, which is going to be, this is a formation of tracheal V. That's what a classical formation of tracheal V at the level of a bifurcation of trachea. Just have a look at this. In a grayscale, I know that this is trachea, and this is one V. This is one vessel, under vessel. This is formation of tracheal V, and this is superior vena cava. So that is what I will be able to identify. I'll be able to identify this at appropriate time. What I should be able to identify is that okay. Once I look at it, which are the 12 points I should be able to identify in three vessel and three vessel trachea view. So LVOT has to be at origin with an angle. The size has to be appropriate. Look at these aortic valve, it has to be quite normal. At right outflow tract, the size, look at the size, it should not be smaller, it will be similar, but it originates without angle. These are the 2 points about the LVOT. Now coming to three vessel view, it has to be three in number. Size, as I told you, large is pulmonary, aorta, and then superior vena cava. Arrangement has to be PAS. Arrangement has to be anterior to posterior. So that is how you identify. And three vessel trachea view, the direction of the flow has to be on the left hand side. The size has to be similar. Blood flow should be of the same color, and the thymus has to be evaluated. So overall, these 12 points for four chamber, and these are the 12 points for outflow tract. The moment you have identified these things, then you will be able to identify the outflow tracts. There are good outcome, fair outcome, and poor outcome. I've just put it across just for you, just to identify how you can counsel. So, but in India, there are quite a lot of things. There are structures to right hand side. So there are 12 structures which you need to identify and understand. So aim of your echocardiography has to be identify 12 structures: suatria, two ventricle, pulmonary artery, aorta, so two major vessels, veno-atrial connection, atrioventricular connection, and ventriculo-arterial connection on the right and left hand side. The moment you have identified these 12 structure, then your echo is good. You have done justice to the patient. Any 12 structure, if one structure is affected, then it has got a good prognosis. Two affected, less good prognosis, but still fair chance that baby may survive. More than two, it always will have poor prognosis. This is as a thumb rule. If you understand, if you follow this, you will have. So that's the reason I always say, if you follow the rules, if you take some precautions, how to identify, and make sure that you have got a brilliant good presets. Unless you have got good presets pre-installed in your machine, you will never be able to identify your cardiac malformation and the structures, and that's how you should be doing. Use your gadget to its optimum best. This you can utilize your machine to at the best potential if you know your machine better. It's like if I whatever car I'm driving, if I know precisely how my car works, how it is going to run, and what are the functions it has got, then I can drive it to the best. If I do not know, if I straight away I wanted to ride the Ferrari, if I have never understood the Ferrari, then I definitely am going to end up in a disaster. Don't do that. So use your optimum, you get optimum best, and if you do not know, please take help, learn, and then otherwise you are going to end up in a disaster. Thank you very much. So for my recommendations, I'll put it across. The echo is easier than you think. Grayscale, HD flow, color and slow flow and the settings are one of the most important. I always use the stick and it will add the value to your precision. So 12 sections, four chamber, 12 sections for outflow tracks, and most cardiac malformation will have similar features in both trimester. It is the size, not the gestation, which matters the most. Key to learn fetal echo is precise knowledge of cardiac embryology and also the cardiac anatomy. Thank you very much for patient hearing.
Thank you, sir, for a wonderful presentation. You definitely simplified it, and we are doing echo. It will further help us more. Thank you so much, sir.
Thank you.
So we may go on to the next presentation. I think we'll take the closing remarks at the end. So once again, I call upon Dr. Kanchan. Sir, can you introduce the next speaker, Dr. Prasanna?
Absolutely. Sorry, I got cut off for a brief few seconds. Prasanna, it was Prashant, it was an amazing presentation. I know how much you have covered in this short time. It's
Thank
not
you.
easy. Wonderful. Now, I take particular pride in introducing Prasanna because we are from the same place, and he is the rising star from Bengal, I can tell you. He is one of the directors of Ultra Clinic in Asansol and doing wonders at the national level. I know how difficult it is to follow a perfect speaker like Prashant Acharya, and we every now and then we put Prasanna in a difficult hotspot, and that's what we have done. Particularly because he's one of the most favorite disciples of Prashant Acharya. Over to you, Prasanna.
Thank you so much, sir. You spoke my heart. He's my teacher, my mentor, my everything. Good evening, my respected seniors and my dear colleagues. Today, I thank the platform of FitoVision webinars for giving me the opportunity to speak in front of my teacher who has taught me everything about 3D ultrasound and how to use the machine and the probes. I have learned everything from him. So it's a great moment of pride for me to present in front of my teacher, Dr. Prashant Acharya sir. So today I'm going to speak about I'm going to show you a bunch of cases where we at our center use 3D 4D to enhance the detection. So fetal anatomy is three-dimensional. So we are looking at a three-dimensional structure, and we should not be relying only on 2D ultrasound to diagnose normal or abnormal, whatever. I have learned from sir that in our center we do routine scanning by volume probes. We do not start our scanning by 2D probes. We always do scanning by volume probes so that whenever the fetus is in good position or we get a chance, we do not miss the opportunity to take the volume. Like in this case on 2D, you can very well make out that the fetal jaw is receding. There is a abnormal mandible in the fetus. But when you take a volume, when you surface render it, then you can also understand that the facial profile is abnormal. And when you show this picture to the patient or to the referring clinician, they also understand it very nicely that the jaw is receding, it's a severe micrognathia, and there is abnormal facial profile. So what we do in 3D ultrasound is very basic. It is just taking a volume and assessing these cross sections, which we call as the multiplanar imaging. That is A, B, and C planes for us. That is A, B, and C. And this is the render one. If you switch it on, it will come up on default, or you can switch it off just to get the multiplanar imaging. This is a surface rendering maximum mode. That is why you are seeing the bones. If you keep it in surface mode, then you will see the fetal skin. So this is multiplanar imaging and rendering. So how to prepare the fetus for a volume acquisition? These are the 5 basic steps what Professor Ravi Chavi has explained in his book. That is the optimization of the 2D image, that you make the image a little darker, you increase the contrast, make the lighter dark, make of the best reference plane, that in which plane you want to acquire the volume box. You decide the size, that how much of the structure which you are planning to take should be inside the box. It is different for brain, it is different for heart, it is different for the abdomen, it is different for the limbs. So it differs according to which structure you are planning to acquire. The acquisition angle, like in heart, you can keep it up to 15 to 20 degrees, but in brain, the angle should be increased. In gynae, the angle should be much more so that you take all the adnexa. So it depends on which structure we are trying to acquire. And the volume quality and resolution, that is in the machine. You can choose a quality of low. It can be also similar, but it's not always that if we choose the highest quality and the resolution, the image will be always good, because there will be in highest quality, when the fetus will move, you will obviously have some artifacts. So you have to decide that which is the best quality and the resolution according to the fetal movements and your expertise. So this is how you prepare the volume acquisition, like in this case. So what are the tools we are using in 3D ultrasound is multiplanar imaging. We can take the help of VCI, that is volume contrast, and make the image much sharper and contrasty. And we can do a 3D static, like in this case, we are applying the volume box, we are taking the volume, and then we do the multiplanar imaging. We place the yellow dot you are seeing in the screen is the reference dot. You place it on some midline structure which you can identify. Then you align the planes. You align this just by aligning the plane. If you see the C plane, just from the axial view, you can make out the mid-sagittal. So just by aligning it, you can get to any plane whichever you want. That is the advantage of a multiplanar imaging. You can make the image single, you can rotate it on X, Y, or Z rotations. See, we are rotating the image on X, Y, and Z, and then we are trying to get a midline facial profile where you can also see the mid-sagittal part of the brain. So this is called as multiplanar imaging. Then you can use a different tool in a 3D static. You can do it in live 4D also, but in 3D static, if you use the multiple OmniView planes, you can use 3 planes at the same time. You can pass the lines and move the lines. You can rotate the lines after you have acquired the volume. So this is on a 3D static one. So just by passing these lines through the fetal brain, you can, from the volume you have acquired, you can manufacture or you can recreate many or innumerous planes, whatever structure you want to visualize. So this is the OmniView on a 3D static volume. Like in this case, where we are seeing that it's a 16 weeks fetus. We have taken the volume of a spine. This is multiplanar imaging which you are seeing. See, we are aligning the A, B, and C planes, and we are trying to look at the fetal spine and ribs, maybe the scapula, maybe the clavicles, maybe the iliac wings. So this is only a multiplanar which we are seeing. We are trying to align the volumes. Now, this is the C plane. We are making the C planes coronal, and we are trying to identify that what structure we are seeing here. So you are seeing only the maybe the vertebrae, some part of the ribs, but we are really not seeing the entire spine and the ribs. So what to do after you have acquired this multiplanar imaging? You switch on VCI. So vertebrae, you can also see the body if you walk in, and the ribs also. Or still you cannot see all the structures. Now what we are doing, we are increasing the VCI thickness. Just by increasing the VCI thickness, adjusting the brightness, the contrast, and moving the X rotation of the fetus, you can make out the scapula, the iliac wings, the clavicle in a 16 weeks fetus. You can get this image in a 12 weeks fetus also. It is at our center, it's a routine practice to look at the fetal skeleton in detail. Right at 12 weeks, we take a volume and we just do multiplanar and apply VCI, increase the thickness. You will see all the structures, the scapula, the clavicle, iliac wings, the vertebrae, and the ribs in detail. So that was a 3D static. Now, if we apply a live 4D OmniView, this is a live 4D OmniView. What we do is during live scanning, you just apply a line. We draw a line of we use a curve or a polyline in OmniView. And you see when you move that line inside out, you will be able to make out all the structures in the see. We are going inside and we are seeing the body. Now, if we come out the arches, the ribs, you can also make out the clavicle, the iliac wings. So it all you can get so much multiple information just by doing a live 4D OmniView. In this case, you can make out that there is something abnormal. We can see that there is a ventriculomegaly, the ventricles are appearing as teardrop shape, and we can see that there is no CSP. The fox is wide, the interhemispheric fissure is widely separated. So if we want, we are suppose you are not able to go, which structure we need to see? It's very simple. We need to see the corpus callosum. So if you're not able to approach the mid-sagittal, take a volume and then adjust the multiplanar, and you will see we go near first we align the volume, then we place the reference dot on the near the CSP or the anterior complex, and you can already see in the C plane that we are reaching to an axial section. So we take the C plane, make it single, you can turn it upside down and bring the image to the center of the screen. We have still not rendered the image. We are working on the multiplanar only. And if you walk in and walk please take the help of volume, and it is not that you leave the patient here. You always wait to for the mid-sagittal to appear, and but if we try to confirm the diagnosis, then we as a normal nasal bone. But when the patient came to us for scanning, we found that we were in doubt that one of the nasal bones was not proper size. It was appearing hypoplastic. We always rely in such situations on volume ultrasound. You see, we just by placing the reference dot and by moving the reference dot from one nasal bone to other, you can see in this RNT view that this nasal bone is appearing short compared to this. Finally, this fetus turned out as a case of Down syndrome because the previous screening was not done properly. That is a different set of point. But you can make out that one of the nasal bone is hypoplastic, and this diagnostic confidence you will only get if we do a proper volume ultrasound. In this case, the fetus came for a routine NT scan. You can make out that the posterior fossa is appearing abnormal. It is appearing large for gestational age. And when we do the mid-sagittal image, these are all volume images. This is not 2D. On 2D, whenever we find an abnormality, we take a good volume, and you can make out that what is missing in this case, in a cystic posterior fossa or an enlarged IT, the missing structure is the choroid bar. So you cannot see the choroid plexus of the fourth ventricle. So we can with high diagnostic accuracy, we can tell the patient that this fetus might go on to develop a posterior fossa malformation. Then you can give all these rendered images from your A plane or B plane or C plane, whichever. There are different methods to render from each plane. And you can give these rendered images. You can give the axial. You can just magnify the image and look at the skull sections, whichever section you want, at a much depth and a much bigger view. So in this case, when we warned the patient, she came back to us again at 19 weeks, and this is the image. So you can very clearly make out that that is a cystic posterior fossa. The vermis is rotated. It is appearing hypoplastic. So it is a case of Dandy-Walker malformation. And when you render the case, you can see that how cystic and the posterior fossa is, and the vermis is rotated. Again, cystic posterior fossa, and you can also make out that whether the corpus callosum is appearing normal for gestation or not. So people who are scanning regularly, they know that this is appearing short at 21 weeks. So this is another mode of 3D which we regularly use at our center. We use TUI, that is tomographic ultrasound imaging. It is just like a CT scan. These are all parallel planes. You can get a parallel plane from whichever plane you want, A, B, or C. And in a single image, you can make out a lot of findings just by arranging these slices. There is a slicing, get the perfect mid-sagittal, and then we always do a measurement of the BV angle. In this case, you can always already make out that it's a case of Vermian hypoplasia or Dandy-Walker malformation. And you can also make out that the corpus callosum is hypoplastic. So on 3D, it gives us a much more diagnostic accuracy rather than just a simple plain 2D. Steer on your corpus callosum. You can, for diagnostic accuracy and 100% foolproof method is always to do a 3D ultrasound. You can make out the teardrop shape, the widely separated interhemispheric fissure, the widely spaced parallel lateral ventricles, the steer horn shape of the frontal horns, and you can see that the abnormal cingulate gyri in cases of agenesis of corpus callosum. This case, there was a cystic mass in the brain. Somebody had referred to us with a cystic SOL in the brain. They forgot to switch on color. So you switch on color, and you can easily make out that there is a hypervascular mass in the brain. So what we do here, we take a volume. It is just to show you a simple thing. We take a volume, and then we start aligning. We are not seeing the entire, we are trying to walk in and walk out and do the rotations and trying to see whether we have acquired all the vessels which are there or not. But we are not finding it, right? We are not finding all the vessels we have acquired. So we do all kind of rotations, and we walk in and walk out. We do X rotation. We do Y rotations, and then while rotation you find out some of the vessels here. So this is a case of a vein of Galen. But what did we do here? We switched on VCI. Same like spine, we switch on VCI, increase thickness, you will get to see all the vessels which are there in your volume. So we apply this simple trick on VCI, and then we get to see these kind of malformations, and you can render them also. And this is a case of a vein of Galen malformation, where you can make the patient easily understand that what is the vascular malformation in the fetal brain. So in this is a very interesting thing which we follow at our center for situs. Sir has taught us situs in a different way, and we follow at our center. We just take a volume. We do it at every case of NT scan. You can make out that this is the left hand of the fetus. See, we are walking out and we see this is left hand, this is right hand. This is silhouette mode of HD life. So you can already see in without even walking in silhouette mode, you can make out that this is the stomach, because you have taken the volume yourself. See, we walk in, see this is the stomach bubble below the left hand. So it's a normal situs. We call it as autositus in our center. We just take a volume of the fetus, we walk in, walk out, apply silhouette mode, and then we get this. Now, in this case, if the vessels are in clockwise, that is the spine, stomach, and umbilical vein, if it is in clockwise, you can see it is in clockwise, the head should be on the caudal side of the mother. But you can make out very nicely when we move the probe to the upper part of the abdomen, we are seeing the head is on the cranial side. So we suspected a situs inversus in this patient. What we did, we took a volume as usual, and this is a volume. You can make out this is the left hand. This is the left hand of the fetus. This is very easy to understand. And you just walk in. You just walk in on this volume. See, we will walk in on this volume. And when we start walking, you see this is the stomach. So stomach is below the right side of the fetus. This is left hand and this is the stomach. And this you can also do in the silhouette mode, where it becomes much more easy to visualize the stomach. And also you can do a magic cut with a defined depth. If you apply a box inside and then you do a magic cut with a defined depth and you cut, then also the advantage is you keep the fetus and you show the patient that, see, this is the fetus and this is the stomach, it is on the right side and this is the left hand. So this is how we diagnose situs abnormalities at our center. In this case, in their case presented with a short FL, abnormal femur foot ratio, and we got a bulging forehead. So we take a volume, we show the patients who we suspect achondroplasia in this case, and it is much more easier to make the patient and the clinician understand that, wow, what a bulging forehead looks like in this 33 weeks fetus. This case, you can make out that there is something wrong with the spine. On 2D, you can make out that there is a scoliosis, and these vertebrae are not appearing normal. They are not appearing complete. So there is a wedge, and you take the volume. You should not diagnose only on the 2D ultrasound, because there are maybe multiple problems which may be associated in this case, especially problems with the ribs. You cannot make out the ribs if you do not do 3D. So we always do the 3D, and you see that this level of vertebra is half. This is the case of hemivertebrae. Again, this is a severe case of kyphoscoliosis of the spine. You can make out on volume, but you can also make out that these are abnormal ribs. So to make out this abnormality of the ribs, you need to do a good 3D. And when you render this, you get to see these kind of images. Another case where you can see very well make out on 3D this shape of the spine, this scoliosis or the kyphosis is much better appreciated on 3D rather than two-dimensional ultrasound. In this case, what we had a echogenic linear structure at the level of the cervical vertebrae at C7. We were really not sure that what that structure is. So we did a volume ultrasound, and then after using multiplanar imaging and rendering that, we can see that some structure is abnormally jutting out from there and not even completely forming a rib. So we suspected a supernumerary rib in this case, and we did an we did an invasive testing. This is a case of cleidocranial dysplasia. You can also make out from the VCI images that something is abnormal with the C7 vertebra. And you can make out that the clavicles, this is a volume image. You will not see this on 2D, that the clavicles are not forming the entire shoulder joint. It is not reaching up to the shoulder joint. So this is hypoplasia. So cleidocranial dysplasia is not always aplasia. It can also be hypoplasia of the clavicles. In this case, you can make out on these. We all use a lot of 4D VCI when we do skeletal imaging. You can see that on VCI you can make out that there is abnormal shape of the upper limb. So this is the case of a claw hand. So these kind of skeletal images, we always do a good volume ultrasound and render them in maximum mode. This is HD live, but if you want to see it in maximum mode, you get to understand skeletal problems much better. So in this case, again, a claw hand, and you can on 2D also you can make out the problem, but when you do a maximum mode rendering, you can make out that you can only see the ulna. There is no radius, so it is very easy to understand on a maximum mode rendering that which bone is present or absent. And the fetus had a claw hand and an abnormal thumb. In this case, again, we are using, so what mode of ultrasound we are using? We are using a 4D BCI, where we see that bilateral absent fibula and micromelic lower limbs are there. Always in skeletal problems, we use a 4D BCI, live 4D BCI. In this case, what we are seeing here is there is a limb problem. You can make out on this live 4D surface rendered mode, HD live, that there is the missing part of the limb. And again, for live 4D VCI, you can make out that the part of the limb is missing. The clarity and the contrast of the image is much, much better than just a simple 2D, to make yourself confident and also to make the patient understand. And this is a case of a missing foot. And so to assess club foots, as Adi sir has already showed us in the case on 2D, you can suspect the diagnosis, but to be sure and to make the patient understand, we need to render them in maximum mode or HD live surface modes. This case, you can make out that the lower limbs are fused. So to make out whether the bones are fused or not, the bones are not fused. You can see that the bones are not fused, but the soft tissue is fused. And when you render the fetus, so this is a case of a sirenomelia, where the lower limbs are fused with each other. When we take a volume and you see that there is no branching of the abdominal aorta, because this is a case of vascular steel phenomena is there in sirenomelia, so it does not give any branches. This is a case of a fracture in the lower limb, unilateral lower limb. You can make out on 4D VCI so nicely that there is an elevation in the abnormal contour of the lower limb in one of the limbs. And when you do a rendered imaging, and this is a TOP picture of that same fetus, this is a case of osteogenesis imperfecta type 3. So you can make out that how the relatives or the patient or the doctor or the referring clinician can relate this volume image, rendered image, with this TOP image of the fetus. In this case, there was abnormal hands and feet in all the four limbs, that is upper and lower, both of them. And we can see that there is a cleft-like thing in this. See, the foot is abnormal. You can make out that there is ectrodactyly in the limb, and when you render, you get to see this ectrodactyly or this split in the lower and the upper limb. So this is a case of hand foot split malformation, which we proved by genetics by doing a WBS for this case. Yeah, again, use of volume ultrasounds. We can draw we can draw a line via OmniView just through the upper face, and it's very simple. Yeah, and go to maximum mode, you will get to see all these fetal skull bones. So we need to understand the machine when you need to use whatever apparatus the machine is giving us to make our lives easier, and we get to see these sutures in the fetal brain. We know that abnormal sutures in fusion will be there, or the opening will be there in which cases. In Apert syndrome, there will be abnormal widely open sutures. In cases of holoprosencephaly, there will be premature fusion of this coronal frontal suture, metopic suture. So again, if you want to see the lateral sutures, again, it is the same. We take a flat box depth volume. We always take a flat box for surface structures. and then we take the volume. And just by taking the volume and going to maximum mode, you don't have to do anything else. You can see this coronal and the sagittal sutures in the fetal brain, and you can get pictures which like this, where you can point out all the fetal prenatal bones and the mandible, the temporal, occipital, parietal, and frontal, and also the sutures. You can make out the sutures so nicely in this maximum mode. So we come to the heart, and we will show you a few cases where you can make out in this heart that uh, we can see that the outflow which is coming, there is an I sign on 3VT, and the outflow which is coming out are parallel outflows. We can see that there is parallel outflows. So any heart abnormality, we always do a stick, and we take a stick, and then we can render also. We can do one VCI also, and you can make out that the first vessel which is coming out from the heart is bifurcating, and you can also make out the parallel orientation and also the VSD. So this is the case of a TGA with VSD. Now in this case, yes,
we need to wrap up in maximum 5 minutes.
Yes, only 5 minutes, sir.
Yeah.
Only 5 minutes. So in this case, you can see on 4D VCI that there is a gap in the ostium primum, and when you render the heart, you will be able to see that there is linear insertion of the valves, and you are seeing a case of a partial AVSD. So this was a case of a trisomy 21. You can get the light behind the heart and adjust the edit light functions, and you can very clearly make out that where the septal defect is, and this was the case of a partial AVSD. In this case, again, you already saw in the 3VT level that there is the N sign. So we know that the diagnosis is most probably we are dealing with a double aortic arch. But to make the patient or the referring clinician understand, or to increase our diagnostic confidence and accuracy, we take a volume and you can render the images. And how to get this ensign or get this both the arches. You can see both the arches bifurcating, right? So if we start with the multiplanar, just align the align the planes, and get the reference dot to the aorta. That is how you get to the rendered image of a heart. Get the reference dot to the aorta and get to the plane what you are finding, and then we need to recreate this A plane. So it's in default in stick setting that it is a front back rendering pattern. So we do thin render for the B plane, and automatically you can see that the rendered image you are getting for the B plane, because it's a front back rendering in default setting in stick. So we get to the rendered image, we do an X rotation, and you do a Y rotation, you walk in and walk out, and then you will be able to see that this is the pulmonary which is bifurcating, but the aorta is also bifurcating. Like so, this is a case of double aortic arch, and this is how you can spatially arrange the vessels and make yourself sure and the patient understand that it is a case of a double aortic arch. In this case, again, you can make out that there is parallel orientation of the vessels, and the clip is not running. Okay, there is parallel orientation of the vessels, and we do a stick. And what you can make out in this stick in similar in one plane only, you can make out that there is a big VSD. You can see that the IVS is ending here only. There is a big VSD. Inflows are okay, but so where is the VSD? The VSD is below the pulmonary. So it's not below it's not doubly committed also, but it is mostly below the pulmonary. So this is a case of not simple DORV. This is a case of a Taussig Bing anomaly, which you can easily diagnose if you apply a proper stick. And if you render it, you will get to see these kind of beautiful images which our machine will give us. In this case, where you can see that it's a 4-chamber. It is not running. Okay, we'll skip it. It's not running. So in abnormal, I don't know why the clips are not running. Okay, we'll skip the slides. Anyways, we don't have time. There is some problem with the slides, sir. I think we are almost done.
Don't worry. I mean, what you have shown was amazing, mind-boggling images. So I presume you've finished, Prasanna?
Yes, sir. Yes, sir.
Right.
I think
Any
it's
comments from
hanging.
my co-chair, Dr. Vinita?
A wonderful presentation, and it was really very good to see. I think we need more of practice so that we can also render such images. Thank you so much, sir, for a wonderful presentation.
Prasanna, nice images, Prasanna.
Thank you, sir.
That was truly beautiful. All the images, I mean, we are at loss that we couldn't actually go through the whole of it, I believe. Right,
Yes.
sir? Yeah. So, any for all the three sessions, if anyone wants to make any closing remarks, Kanchan sir, Dr. Vinita, madam. I know we are running short of time, but
Yeah.
at all,
Wonderful presentation by all the presenters. It was really nice listening. It was a great learning also for us. And I attended sir's lecture in the Jodhpur. And it was again a revision. And I think I need more of revision to be as expert as him in the 3D. And Dr. Acharya is mind-blowing as always. All the three speakers were wonderful. Thank you so much for such a lovely webinar.
if Dr. Kanchan sir, if we could go ahead with the next,
Yes, please. Yes,
your
please.
permission? Yeah.
Go ahead for the panel
Yeah,
discussion.
panel is there, yes.
Sharma, before the panel, you need to play the industry video.
All right, yes, sir. Can you, Himanshu, can we go through the industry support video? Please play it on.
Whirlpool stands hand in hand, witnessing the birth of a new day. To the boat sailing towards the horizon, seeking its abundant catch, the rising sun signifies a fresh start, a beacon of light guiding us towards a healthier future. A mesmerizing sunrise, symbolizing hope, transformation, and possibilities heralding a new beginning. Just as the sun's rays fill the sky, illuminating the world around us, we at M-Fine Diagnostics are here to illuminate the path to a healthier tomorrow with the promise of transformation. In this symbolic moment, we invite you as M-Fine Diagnostics, formerly known as LifeCell Diagnostics, embarking on a journey to revolutionize India's healthcare system. With the recent acquisition by LifeCell Diagnostics, M-Fine Diagnostics combines the strengths of two leaders, forging a path towards a healthier India. Our commitment to excellence, nurtured by years of experience, will redefine the way healthcare is delivered.
At NRL, we cater to a test menu of 3,000 plus tests. These are all specialized tests, and they cover various high-end specialist tests like genomics, karyotyping, FASH, newborn screening, prenatal screening, immunohistochemistry, allergy, and flow cytometry.
Come, let's explore a realm of innovation and compassion. Here, the convergence of science and care sets the stage for a new era in healthcare. Inside our state-of-the-art facilities, skilled medical professionals work tirelessly, employing the latest advancements and breakthroughs. We believe in leaving no stone unturned in our pursuit of accurate diagnostics and comprehensive care. With M-Fine Diagnostics, you can trust that your and your patient's well-being is in the hands of dedicated professionals, guided by a shared vision of transforming lives. At M-Fine Diagnostics Lab, we combine expertise, advanced techniques, and timely reporting to provide you with the most reliable histopathology services. Trust us for accurate diagnoses and comprehensive solutions. Our integrated departments and highly trained professionals equipped with advanced technology deliver high-tech tests with speed and accuracy. Automated sample management guarantees faster results, while our focus on quality is unwavering. At M-Fine Diagnostics, we prioritize seamless experiences for patients and doctors. Our dedicated customer care ensures hassle-free services, patient convenience is key, and we offer real-time logistic tracking, allowing patients to stay informed about their specimens. With strong logistics support and real-time sample tracking, we ensure smooth operations. Our mobile application provides a flawless user experience, enabling easy test searches, bookings, and result downloads. Our enhanced customer experience includes auto-routing bookings to the nearest available phlebotomist and a user-friendly portal/mobile app. Our skilled phlebotomists collect samples efficiently, maintaining specimen integrity during transport to the lab. Adhering to NABL and CAP guidelines, we uphold the highest quality standards in the industry.
Together, we can set new benchmarks of performance and excellence across the country. We are excited to collaborate with you in catalyzing game-changing diagnostic innovation for those who need it most. Thank you for your support.
Thank you, Himanshu, for that video on the industry support. Can we have the next video played? Himanshu?
Yeah, I just wanted to mention that we are still sticking to the early bird dates because of a problem with Meta. We couldn't send the bulk WhatsApp messages, and also because of Try, we couldn't send the bulk SMS messages. So that's why we're continuing with the early bird rates. And we still have some places left, very few places left in the intervention workshops.
Thank you, sir, for that. And for all those who have joined in late, I'm sure you must have marked the dates on it. That is April 19 to 21. Do not miss it and be there at Kolkata for the Fetovision conference. And now moving on because we are running short of time. I think we'll move on with the next session. Bhaskar sir, shall we?
Yes, please. Yes, please.
Yes, yes. So moving on to the next session, that is a wonderful panel with that is anomalies detected. What next? Which I'm sure each and every obstetrician, be it a fetal medicine specialist or an expert, but other than that, even the primary obstetrician, we have to face such things. So I take extreme privilege to introduce our moderator for the session, Dr. Varekar sir. Sir is the director of Varekar Hospital and Greenleaf Hospital, fetal medicine specialist at Perfect Diagnostics, and he was immediate past president of the Surat Obstetrics and Gynecological Society. So, sir, I take extreme privilege to invite you to our webinar series, and I may ask you to introduce the panelists. The next slide, please.
I think we have the our esteemed panelists for the session, and that's Dr. Ashita. She is a gold medalist and working as having done fellowship from Institute of Fetal Medicine, Kolkata. She's a consultant fetal medicine at Nishant Hospital, Patna, and it's a pleasure to have you on the panel.
Next slide, please.
I think I have it in my slides, so I can take it from there as well. So we have Dr. Jagruti Mukhi. She's from Amravati and Director Fetal Medicine Unit of Daffodils Hospital, Amravati, and having done from Mediscan, she is a senior consultant over there. Then we have the next as Dr. Megha Shah. She's a gold medalist in DNB, having done fellowship in minimal invasive surgery and is also interested in high risk pregnancy, PDCC from SGPGI Lucknow. So we have her there. And then we have a professor, Dr. Sangeeta Yadav. She's from Department of Maternal and Reproductive Health at Sanjay Gandhi Postgraduate Institute, Lucknow. So welcome all, and I think we have one more, Dr. Tulika Joshi. She is also a director, consultant fetal medicine at Tulip Fetal Care, Ranchi. So we have a mix of a lot of people from different regions, which can give us insights of how we can practice at various places. Welcome all to the panel. Can I share the screen? Yes. So I think we have seen fantastic videos as well as pictures of ultrasound from the past two sessions, and it's been a pleasure, uh, sitting at the leisure at home and listening to the stalwarts. At the outset, I would like to thank Dr. Bhaskar Pal, Dr. Sitapati Pal, Ramurthy Pal, and Prasanna Roy, National Coordinators, Dr. Sharma, as well as for the introduction. Let's get to the point straight away as we have been talking more on the anomalies. I definitely we all agree that it's a little difficult to cover up so many of them and discuss each one of them. So I thought of coming to points where we matter. So basically, in interesting case scenarios, what we thought was to utilize what we as obstetricians can matter where and how we can use our expertise to treat those patients better. Um, I'm going straight away to the first case being a 23-year-old female, O positive mother, and she's married for around 6 to 7 years, Gravida 4, Para 2, Live 1, NND 1, IUD 1, Abortion 1, having missed her periods, and she has regular periods. So if you go to the obstetric history, we had Gravida 1 in which she had preterm labor, chorioamnionitis, and McDonald's and cerclage was also done. Yet she went into preterm labor at around 24 weeks, and that fetus did not survive. In the second pregnancy, it was a miscarriage at around 10 weeks. And then in the third pregnancy, she again went into preterm labor at around 28 weeks, wherein at 27 weeks, she had undergone emergency horse tightening, but that also didn't work out, and that fetus also was lost. So then she comes as the fourth pregnancy, spontaneous conception and present pregnancy with no significant medical and surgical histories or past histories otherwise. So from the first trimester scan, it was more of a normal first trimester scan with a crown rump lamp of 70 mm, NT of 1.4. The dual risk was also showing a low risk. So overall, a low risk, except for the history. So obviously, in view of the previous encerclage, modified Shirodkar encerclage was done with additional magnetic history and previous preterm. Once that was done at anomaly scan, the ultrasound was normal, wherein it was looked upon for any fine soft markers also. All of them were looking normal. At 24 weeks, we did a fetal echo as well as trying to look for any other Doppler abnormalities, which also turned out to be normal. And then she presented again at 28 weeks with maternal discomfort, difficulty in breathing, and the patient was showing signs of severe polyhydramnios. So when such a patient comes to us, the first question which I had put across to the panelist, Dr. Ashita, if you could identify those points, wherein how do we identify the polyhydramnios and what are the criteria for it?
Good evening, sir. Sir, polyhydramnios is excessive amount of the liger, and when we measure it, the deepest vertical pull is more than 8 centimeter and amniotic fluid index is more than 25 centimeter.
Correct. So would you identify it straight away, or would you want to see her again in a few days to reassess how?
Sir, if it is a borderline case, then I will like to reassess the case. But if it is frankly a polyhydramnios, then I will label it as a case of polyhydramnios.
Definitely. I think we all usually, whenever if it's a very borderline thing, we would like to reassess. So if we put across to what are the causes for polyhydramnios, that is how we would like to progress in this case. So if Dr. Jagruti can highlight
Yeah.
on it.
Yes, polyhydramnios, first thing, this one is severe, but in any case, I would first see for maternal diabetes. And the other is fetal structural anomalies, usually GIT, which come up late, and in such cases, and other are CNS or any neuromuscular disorders. Others can be isoimmunization cases, infections, okay, and yeah, anemias also. So in this case, since anomaly scan was done and it was normal. Hello,
Yes.
can
So
you?
if you see, yes, I can hear.
Yeah, so only there is only polyhydramnios. So again, we need to see for, if it is looked for again in the growth scan structural cases, structural anomalies has been looked again. We need to see for that, like GIT and
Yes.
urinary, genitourinary, because they can
Yes.
pop up
So
later.
correct. So what we look at the all the entrance, especially from the oral
Yeah,
to the
correct.
intracts, which lead to polyhydramnios more commonly. So, Dr. Sangeeta, if you can tell us some of the pictures that I'm showing you and of what Dr. Jagruti has already spoken on the causes. So, how do we identify each of those structural abnormalities in these images?
Yes. Good evening, everyone. So, as we know, once we come across a case of polyhydramnios, we need to rule out the structural abnormalities. So, most common ones are the gastrointestinal abnormalities. So, any atrasias can lead to polyhydramnios. So, we need to see for the stomach bubble. We need to see the anal pit. As we can see very well in this picture, that stomach bubble is very well seen. Anal pit is seen. Spinal abnormalities, then open neural tube defects can lead to polyhydramnios. So we need to see the spine properly, and we can very well see that the spine is normal in this case. Then the picture is showing that there is polyhydramnios. AFI is 37. So as we know, AFI more than 24. This is a case of polyhydramnios. Then we also need to see, because polyhydramnios can lead to preterm labor. So we need to see for the cervical length. And here we can see that this also is normal. So we need to do a detailed anomaly scan, and of course we cannot rule the neuromuscular abnormalities. But then, yes, whatever structural abnormalities we can see, we need to do the thorough ultrasound examination.
Absolutely. And also would you like to see the cervical length in the sense that if it is impacting the cervix.
Yeah.
So if we look at it, we have a case wherein we are not able to yet identify any particular anomaly because of which the polyhydramnios is present. And so what would you like to do next, Dr. Tulika?
Sir, as we have seen the baby and its environment, especially placenta, like if everything is rest of the things are normal, we have to see for the maternal blood glucose levels also. So I would like to order a GTT, and then if it is truly an isolated case, then I would like to suggest her for the either for the mu reduction or the managed polyhydramnios with the by the medical methods. Any
Okay.
prerequisites
So
to take?
yes, go ahead.
Perfect. So the next question is, would you take her up for a mu reduction? Any prerequisites? Usually, in my cases, I see that if the recent blood workup like ANC profile has been done, then I don't usually request. But in this case, I would like to request complete CBC for the patient, and I would like to administer corticosteroids for the fetal lung maturity in this fetus, and uh,
So yes, I think being clinicians first, I always prefer that we at least test them for some basic screening before any form of a intervention that we are planning, uh, just to be on the safer side. So as a routine, I we prescribed the CBC and urine routine, as well as we've done, as you all have suggested, GTT, and it, as the blood group was also O positive, ICT negative, and then it obviously, in view of maternal distress, the first choice is amnio reduction. Uh, so looking into that, when we did the routine investigation, what was found was the WBC count was 19,370, and the blood culture also, I mean, all those things came later, but yes, urine culture showed E. coli, twice confirmed that not it's not iatrogenic. Abdominal ultrasound was showing bilateral hydronephrosis due to stasis. So, looking at that picture, what next thought process? Would you go ahead with the uh, amnio reduction, or would you want to do something else? Dr. Ashita, please.
Yes, sir. In this case, since WBC count is very high, so we can opt for medical management by giving indomethacin 75 milligram twice daily.
Right. So, as we all know, it reduces the urinary flow and then
Yes.
decreases the amniotic fluid. So, what else would you like to monitor onto it?
Since indomethacin is very notorious to cause ductus arteriosus constriction, especially in the gestational age after 32 weeks, and we are near about that gestational age. So I will like to see and close monitoring for ductus arteriosus constriction and the amniotic fluid volume index.
Yes. So, but how frequently would you like to monitor otherwise?
Sir, this is very tricky question since DA constriction may occur even after hours of administration of indomethacin to time many weeks after stoppage of the drug. But at least initially, I will like to see before the before giving the drug, and again I will like to review it after 3 days, and then twice weekly.
Yeah. So initially, I think when you start, we may probably want to see it quite frequently, and then probably we go on to the same, increasing the or decreasing the frequency to monitor. So
Sir,
when we are
if it
looking at
is
it, sorry,
no, sir, sorry.
go ahead, tell me.
No, sir, please continue.
So in cases where we had given her antibiotics to cover the infection, and at the same time, prophylactic tocolytics was given to prevent preterm labor, and indomethacin was started. Uh, and within 48 hours, we saw the count decreasing to around 16,000. And then what I wanted to show from this chart primarily was, as we started looking at it. Initially, the ductus arteriosus was around 4.5, which is the normal zone. And at the same time, whenever it was 75 BD, the AFI would fall very fast. And that's the reason why we kept on adjusting the dose so as to keep the AFI somewhere between 15 to 25. So that's how we try and balance the dosage. In once we were stable by 30 weeks, then for 2 weeks it was almost the same that we had kept the dosage. And towards 32 weeks, when I knew that obviously the ductus arteriosus will eventually will narrow down, and that will lead to stoppage of the drug. So at around 32.4 weeks, when it was shrinking down to around 2 millimeters, is when we stopped the indomethacin. Again, if you see at around 34 weeks, it started rising to around 27 AFI. And then at 33 weeks, we thought of performing the amnio reduction at that time, so as to give a little one more week, which we can get out of it. And then based on it, we moved ahead. At 34 weeks and 1 days, when the WBC count again started rising, is when we delivered a female child 2.2 kg, which cried immediately after birth, and the karyotype was normal when we had done the reduction, amnio reduction. At the same time, um, what I wanted to come up out of this was that we had done the metabolic screening as well as the microarray, which both turned out to be normal postnatally, and the child is doing absolutely fine. So, what was the thought process here is that it was, although we commonly see the last as idiopathic, where we were not able to identify any specific, maybe over the period of time, we might find some metabolic factors or which are not yet been picked up in the metabolic screening as well. But at the same time, we know that it is more of an isolated polyhydramnios, which was leading to hydronephrosis and UTI and preterm labor. So that's what I wanted to come up here with, that when we started looking at around 29 weeks and the AFI was 31, the WBC count was around 19,000. Once we tackled that with the antibiotics and then the indomethacin was started, all through for 31 to 32 weeks, the WBC count didn't rise. As soon as we stopped the indomethacin and the AFI started rising again to 33, 34, the WBC started rising again to 21. So it was instead a case wherein the polyhydramnios was causing to UTI and preterm labor, leading to this kind of a scenario and then preterm birth. So instead of just an incompetent cervix or bad obstetric history, in fact, when I as a tendency, I usually whenever this case was being done at around 29, 30 weeks, I again went through the reports of the previous deliveries and the previous histories. And in one of the consultants had mentioned at 29 weeks when the baby delivered preterm that there was Liker plus plus. So that gave me an idea that there was some factor in the Liker which was causing the preterm rather than just an incompetent or some other reasons for the preterm birth. So if we go on, that's what I wanted to say, that it's about anomalies many times. Yes,
Sir, I wanted to
come in, please.
share a case with similar findings, but it had a different diagnosis at that. So we had a similar case with two previous pregnancies with normal anomaly scans at around 20-21 weeks, but the patient spontaneously at around 24-25 weeks, she told me that suddenly she would be told that the Liker has increased, it was polyhydramnios, and the baby would spontaneously abort within 2 hours at around 26-27 weeks. With two previous histories, and presently also she was pregnant, so I said we'll monitor this case. And when I monitored, the anomaly scan was completely normal at 20 weeks. She came back again to me 24-25 weeks, and she had polyhydramnios. It was a gross polyhydramnios around AFI of 27-28. So at that time, when I searched the literature and everything, I found some renal hyperurination syndromes as well. So we did an amniocentesis for that baby and sent it for a whole exome sequencing and NGS. That baby eventually aborted around after 1 week of after amniocentesis due to polyhydramnios or due to maybe procedure-related problem. But that baby, the test came out with the baby was suffering of Barter's syndrome. So after that, we did a carrier screening of both the parents, and we found that both the parents were carriers of that gene. And in subsequent pregnancy, in fourth pregnancy also, she came to me. We did a CVS at 12 weeks. The baby was a carrier only. Both the genes were not there. So we continued that pregnancy. And then pregnancy went well till 37 weeks. And we did a cesarean due to a precious pregnancy at around 37 plus 4 or 37 plus 5. And that baby is doing well. So it was a similar case with similar findings. Although all others had treated the patient for cervical incompetence. She had undergone and was in cerclage also in both the pregnancies. But it turned out to be something a genetic disorder.
Yes, so that's what we have various causes. One is genetics, one is the structural abnormalities, and many times these patients do have that postnatally. We may find tracheoesophageal fistulas, or there is a small anal atresia, which is a little higher up, not at the anus, which leads to these kinds of polyhydramnios, which is idiopathic. Otherwise, we are not having any other signs. So we definitely try and identify, but there are some cases where it turns out to be idiopathic, and we keep looking for it. And probably, if we look in the right direction, we are able to give the child, the mother, a healthy child. So similarly, we have another case which is Mrs. X, 32-year-old, married for 3 years, conceived spontaneously. low risk, no history of medical disorder, no family significant history. In fact, both were consultant doctors themselves, and had these days we get a lot of WhatsApp opinion on echogenic foci in the heart. Otherwise, everything normal. These were the exact words used by the patients, and they told me that the triple marker test is also low risk, and it's to be 1:251. So this was triple mark. I mean, this was a 2015 case when we were doing those. I think now we don't do much of triple. We do either on dual, or if missed, we do quadruples. So here, if you see, the rest of the things are looking okay, but the triple marker trisomy 21 risk is 252. And so what would you do next, Dr. Jagruti?
I would
32
definitely
year old,
count.
17 weeks.
Yes, but I guess NT scan and that time screening must not have been done, what we do right now, right? So this looks like a quadruple marker
Yes.
test. Yeah, four hormones done. So this is just at the cutoff. I would always call
Yeah.
this as a high risk only. It's just a number game. So I will definitely tell them that we need to not because of the ecogenic focus, but the quadruple marker saying just touching the high risk bar. So I would counsel them for direct testing in such cases. NIPT could be an
Yeah.
option where they don't want to go for invasive. Yeah.
Agree. I think these days it's frequently that we use the NIPT as well. So then she had polyhydramnios at around 29 weeks. If you, Dr. Megha, if you could just update the image and what do you look for in the echogenic foci? We are not able to hear you. You have to unmute your mic, please.
So the image looks like a four-chamber view, but although I'm not able to view the proper four-chamber view, so I'll not comment on the structure of the heart in this image. But yes, there looks like it has around 2 to 3 echogenic focus. Basically, we have to see the movement, the live image or a video of such image to see whether it's the echogenic focus or not. The echogenic focus should be more echogenic than the bone. It should be freely movable, not attached to any ventricular wall, and it should be more echogenic. So that's why I'll have to for evaluation of an echogenic
No,
focus or multiple echogenic focus, I'll look at the video or the live streaming first. If there are multiple echogenic focus or an echogenic focus, then we'll do further evaluation for this patient.
Yeah, it was not working on the PPT, so just don't want to change the sharing again. But otherwise, on the live video, there is proper constrictions of the ventricle, and the fourth chamber is completely normal. So looking at that picture, and would you think anything more in terms of the multiple echogenic foci?
So sometimes when we get referred patient from periphery or anywhere else, sometimes these echogenic focus are not focused; they are larger masses. So there may be cardiac tumors also. So we need to evaluate the patient for that, whether they are only echogenic focus, small, less than 2 mm foci, or they are cardiac masses, which can lead to rhabdomyomas, which can lead to a different diagnosis. Then such patients can also be evaluated for other abnormalities, of course. We need to look for them in the anomaly scan and an echo as well, and some autoimmune disorders also.
Yes. So I agree. In fact, Dr. Sangeeta has to answer this question. So on the causes, but if you can definitely speak more.
Yeah. So whenever we come across the multiple echogenic foci, we first need to rule out other abnormalities. If it is associated with other abnormalities, then there are more chances of having a genetic cause. Apart from the genetic causes, it can also be like a starting thing of cardiac tumor, because cardiac tumors may sometimes present with multiple echogenic foci, and then subsequently when we see after 2, 3 or 4 weeks, they can just grow up and become larger in size, especially rhabdomyosarcoma. So that is what we can see. So we need to follow up these patients. And then very rarely autoimmune conditions also can present with multiple foci. So that might be the calcific echogenicity in the endomyocardium, which might which we can come across in the autoimmune disorder. So definitely we need to rule out these conditions.
Yes, so I think it's obvious that we look not just at the image perspective, we look trying to look why that has come that way. And so when I mean, I had certain articles which I read at that time, and I was strongly looking for some autoimmune factors to be into it, looking at her history. So I had just done, and it turned out to be Sjogren's that was positive. Here, what happened was that obviously the consultant, both of them being doctors, had looked into a lot of research online and decided that it's autoimmune, we will not go ahead with the we will not go ahead with the procedure. And then they delivered a female child, beautiful 2.4 kg, which turned out to be Downs for trisomy. So 21. So when we were looking at these aspects, and what I wanted to come up onto this as clinicians, what we many times forget here is that image of which I think Dr. Jagruti also mentioned, as the quadruple test is there, we try and understand the risk of age being 1 is to 660 instead, and this is 1 is to 252. So although if it would have been 249, it would have been labeled as high risk. Since it was 252, the lab labels it as low risk. So it's not about high and low. We have to clinically assess why the 660, where here we normally would have seen 2,500, 1,500, 1,200, or 10,000 as the risk. Why has the risk gone high? And then if we put the echogenic foci into it, which I mean, we can consider it also it's a soft marker. So very, very, very small factor. But in spite of that, it would definitely increase the chances into a higher risk. You're looking at those factors. I think it's many times more important for us to not just look at one aspect causing this kind of innocuous findings, but looking at these innocuous findings as very important markers towards the actual diagnosis. And so while we, obviously go through this, I would want Dr. Tulika, if you could also tell me what's your protocol on the down screening, although a very common question.
Okay, so I usually offer universal screening to all my patients in the first trimester itself by anti-scan and then by the double marker test for the combined screening. This is called as combined screening. The patients who miss that window, they are usually offered a quadruple marker test in the second trimester. But if there are some other indication that I should go for a higher testing, such as increased maternal age, then I offer them the NIPT. So this is my protocol.
Absolutely. So would you prefer if there is any structural malformation or if there is a structural a soft marker, then would you still go for NIPT?
So if there is only one soft marker and the mother's age is usually on the younger side, there is no need for NIPT. If there is only one soft marker, we can go with the quadruple marker test.
Once you
But if it is a stronger marker, this is absent nasal bone, then we can give her the cafeteria choice that she can go with the either.
Yeah, so once you have any structural defect that you may have or a structural problem that can be seen, then it is more towards the diagnostic test than the NIPT. NIPT will be more of the biochemical risk, giving us a high risk. That's what has been still proposed as we continue. So we did a small study because there was a lot of confusions, and there was one study which I was doing, which to get a diversified view of how people at different regions and levels across the country do have their protocols. And if we see somewhere in Delhi, Dr. Anita was doing more of EFTS and IPT protocol detecting in this manner. At the same time, we had somebody who was still doing an IPT anti-scan with dual marker and an IPT. Some still at the cutoff of 250, others considering the cutoff of 1 is to 50. Then Dr. Prashant was here. He considers the cutoff to be 1:100, considering uh, protocol as the NT, NB, NDV scan, and then high risk protocols as NIPT. Then we have, in this manner, what I wanted to say is that what is one important aspect is definite that we all need to do the first trimester screening, and it is definitely indicated for all cases. But at the same time, triple marker is something that none of them mentioned. So it purely tells you that where our standards have shifted. The first trimester screening being the best one. When in doubt, direct testing is definitely warranted. NIPS has no role if any abnormal ultrasound is, I mean, limited role, I would say, rather than no role. And microarray is the preferred choice over my karyotype. Friends, what is important here is that we many times see that some consultant has used NIPT, the other one is not using. I think we are in a zone where, based on the scenario, which is a local scenario, the availability of the tests as well as the patient counseling and the patient choice takes up a huge uh, aspect where which kind of screening to be done. But it's definite that we do a first trimester screening with dual because now it is one standard and then we take it further onto it. But the best form in descending order would be EFTS plus NIPS. If FTS followed by NIPS, FTS followed by genetic sonogram, quadruple marker, genetic sonogram, triple, but at least some form of screening, especially becomes important when we find some abnormality in the second trimester or soft markers in the second trimester, then the ones which we have done in the first trimester, like in this case, if first trimester testing would have been done and may have been on a high risk, or the nuchal fold or the nuchal thickness was a little on the higher side, we would have been more vigilant in terms of identifying towards genetics rather than looking at the autoimmune side. So that's what we have for here. We have two cases here for this, and I think are finishing on time at 9:30 for what we have. So, friends, before I finish, I would like to thank the panelists, and if they would want to convey one sentence which to the routine of OBGY of improving their practice in routine. Can I ask each one, starting
Sir, I
from
would
yes,
like
Dr.
to start. I would like to start the practice of whenever the double marker test is positive, especially in the Jharkhand region where I practice, the obstetrician directly goes for the quadruple marker test. And I want to convey that if one screening test is positive, we have to go for a confirmatory test. And
Absolutely.
with the confirmatory test, first thing is the detailed ultrasound examination by a specialist. So, sending either of the screening tests, either for first trimester screening or second trimester, without any scan is also not useful for the patient. It's just like draining the money of the patients.
Yes.
Absolutely. I think that's a
And
very
whenever,
important. Jagruti, yes.
yeah, whenever there is any anomaly detected, and you are suspecting any genetic abnormality, so Down syndrome is not everything. Doing a double marker, quadruple, or NIPS is not going to give you an answer. A direct invasive, that too, depending on the findings, we need to decide what you are going to test on the baby. So even that is important because everybody just does a quadruple and thinks that okay, if that is normal, there is no other genetic condition. So that is
I
also
agree.
one thing which
In fact, I am a very, I always feel that first trimester screening, although a lot of, we charge differently for a Doppler, but I think it is not complete without the uterine Dopplers and the dual, also the biochemical screening, apart from the down screening, is extremely useful. I think it's a complete different topic and it takes an hour to make things clear on it, but pre-eclampsia screening is, according to me, a much more important aspect apart from the dual and down screening that we get from the dual marker. And utilizing that uterine Doppler along with the dual gives us a lot of weightage on screening for preeclampsia, especially when we see about.
Huh?
So, uh, I think next, if we can have Dr. Sangita or
Yeah, I think everything has been said, but one thing is very important that whenever we do screening, it is very important to do counseling of the patient. Like if the patient, if it is low risk, even then it is not absolutely like the baby is absolutely normal, and we need to look at the complete picture. We need to see the ultrasound findings, and even if it is low risk and we are seeing the ultrasounds of markers, then it is better to go ahead and do invasive testing.
yeah, better
Sir,
test
can I
than
say?
and yes, last meeting.
Sir,
I
in
think Dr.
our part, hello.
Yes, yes.
Yes, sir. Can you hear me? Sir, in our part, many of the gynecologists are doing their own scan, especially early pregnancy scan. So I just want to convey them that if they are doing their scans, please try to find out whether USG EDD are in agreement with the LMP EDD or not. Many of the times EDD are not being corrected, and in the end of in the third trimester, we are completely blindfolded that whether it is IUGR, what is the centiles, and there is a total mess, sir. So I just
Yeah.
want to convey them that please take proper CRL and take whether it is do corrected EDD if there is a change
I
in
think
discrepancy in both the EDD.
we would like to see that. I think Dr. Bhaskar Pao wanted to
No, no, I
say
just
something.
wanted to, as an obstetrician who doesn't do fetal medicine, I just wanted to reinforce the point that Dr. Tulika made. That if you have one screening test which is positive, do not go for a second screening test. You know, once upon a time in UK, a group of people started this integrated test where they'll do a first trimester screening and they'll do a second trimester screening. And if one is positive and one is negative, you're nowhere and you're not doing the patient a favor. If you have one screening test that's positive, just act on it, go for a definitive test. Whether it's an NIPS, whether it's a invasive test. That's all I wanted to say. I think it's a very important message to go through.
Yes, yes, absolutely.
Thank you, sir.
That's very true. So at the end, I would like to definitely thank, and I think we could do justice on what obstetricians would love to know on this topic. Thank you very much, everyone.
Thank you so much.
Thank you, sir.
Thank you.
Shama, back to you.
Yes, thank you, sir.
Yes.
If we could have any more inputs, Sita madam, the three speakers of the session, Adi sir. I think Prashant sir has left, is it?
Yeah, I can see
And
Adi is still
Prasanna.
there, but
Yeah,
Prasanna has
Prasanna,
also
Dr.
left.
Prasanna. Yeah, okay. Sita madam, if you could have some closing remarks on the topic.
No,
And
it was
and
fantastic. Sorry, I can't put my video on, but thank you so much for the talks. Were really fantastic, amazing talk by Adi. Dr. Adi, very beautiful depiction of how we can clarify our confusion. Prashant sir, as usual, giving his simplified tips on doing echo, and beautiful Picasso images as usual from Prasanna. And thank you, Darshan, for a very practical panel on how to go about looking for how to go about screening for anomalies, not to always think, laterally and think that it could be something and give the patient the choice and document everything. Thank you, all the panelists. It was really very informative. Thank you so much. Thank you.
all
Thank
right.
you.
So I think, yeah. I think I'll go on to the official vote of thanks. A deep gratitude to all the esteemed faculties who took out their precious time actually and shared such rich clinical knowledge on the topics. Like just like Madam said, Adi sir, his usual beautiful flair of creating from confusion to clarity. Then Prashant sir, he was like a gem of a person who's always, as always, all his talks we have those dissection specimens which leaves imprints in our minds. You'll never forget anything. Either he holds a brain or a heart. You always find that it leaves a mark on you. And yes, as Madam said about Dr. Prasanna, those images, it was really wonderful. And he also had, that from the confusion to clarity, 3D, 4D, how do we enhance our diagnosis? So that was all I wanted to say. And special thanks to Dr. Darshan sir for the beautifully framed questions and those practical points. Like really practical, what we face or obstetricians usually face in the OPDs. Those clear take home messages after the interaction from the wonderful panelists. And of course, I want to thank the master brain of the whole program, dear Bhaskar sir and his better half, Sita madam, for taking. And I take this opportunity that I could also learn and relearn. So much more was there. And also our pharma support, that is the M-Fine Diagnostics. Thank you all for your patience, hearing, listening. I think we were supposed to be, right on time. We started off, but we got carried off. It was a wonderful session. Last but not the least, I really want to end the day post holy sessions. Keep safe, play safe, and thank you all. Have a very good night, sir. If you want to add on to
No,
anything.
thank you. Thank you, everybody, for your time and for your inputs. Thank you.
Thank you.
We meet
And
again in the
until the
last
next.
weekend of last weekend of April, and before that, I guess we meet in Fitovision, most of you.
Yes, Fitovision. We
I
all.
still haven't seen Jagruti's name, but I think I've seen most of the others.
Yes, sir. Yes, sir.
See you.
Yes, thank you.
Jagriti,
See you all at
taking
Thank
forward.
you.
Mhm.
Thank you so much.
Definitely, Fitovision, we are there, sir. And next month, it is on the 30th, I believe, sir.
I guess.
April 30th, yeah. All right. So thank you so much.
Thank you,
Thanks,
sir.
Good night. Good night.
Good night,
Good night.
everyone.
Good night.